Hey everybody, welcome to the last presentation of Module 2. We're going to talk about elbow collateral ligament reconstruction, also known as Tommy John surgery, named after a baseball player, pitcher actually, who required this surgery. He was the first one to get it. So we'll talk about the history a little bit, just because it's interesting. I put together this slideshow, but we had another expert named Eric Hodges, who actually helped with this one because he sees a lot of patients who have had this surgery. The surgery is very common in the United States because it's primarily done on baseball pitchers. So again, the history behind it's a little bit interesting. But I would also say that here in China, I've seen it twice, and they were also for athletes who needed to do throwing as part of their athletics. So this is something you're going to see sometimes, but probably not very frequently. We're going to spend a little bit of time today talking about throwing mechanics and returning to throwing. And again, this is primarily for baseball pitchers, but if you're thinking of your tennis players, your badminton players, there are a lot of other people who might be doing throwing. So it's still relatively relevant, I think, for a large number of your athletic population. So, quick little review of elbow anatomy. If you remember, we are thinking about the humerus and its articulation between the ulna and the radius. And we're primarily focused on the ulna, so the radius doesn't have a lot to do with this one because we're talking about the medial collateral ligament. So if you look at the anatomy here, we have what's called the ulnar collateral or medial collateral ligament that's on the inside of the elbow. And you'll see here that the ligament itself is actually in three bundles or three portions. And we'll go into a little bit more specifics on that here. So you have what's called the anterior bundle, the posterior bundle, and the transverse ligament, basically, that all sort of work together as what we call the ulnar collateral ligament. The anterior bundle tends to be the one that's torn the most frequently, and you can see that sort of in the picture on the right here. And the reason that is true is because we should have some mobility and stability from that medial and lateral collateral ligaments, just like we do in the knee. And what we are hoping for is that they are stable enough to be able to support varus and valgus forces. And so if we're going too far out of a varus or a valgus force, then we're likely to tear or strain a ligament. In this case, we are causing an increased valgus force at the elbow, which then will cause too much pulling on that medial collateral or ulnar collateral ligament. So these injuries first started, probably a very, very long time ago, but the history of the surgery is from 1974 with a Dr. Frank Jobe, and he actually worked with this guy named Tommy John. And Tommy John here was a pitcher for the LA Dodgers and was doing very well, and then had an injury mid-season, and he was feeling pain in the medial side of his elbow, and then the most important thing was that he was unable to pitch. He was unable to do his job. And so Dr. Jobe came in and decided he was going to try to somehow fix that medial collateral ligament. This picture actually is a picture of my cousin. My cousin, his name is Jeff Manchip. He was a pitcher for multiple teams, including the Cleveland Indians, who went to the World Series. I wish I could remember the year. It was maybe 2016, I think. So that was pretty cool. This is him. He actually has had this surgery. It's a relatively common surgery for pitchers, but we're going to talk about how it's important to make sure you're choosing the right patients, the right athletes to actually have the surgery done. The surgery has increased by 50%, and with 50% of the high school and middle school athletes having this surgery, 28% players and 20% of coaches think that it's going to help improve throwing performance. which is very frustrating because, you know, we're doing this surgery and then we're doing rehab for these patients and they're thinking, wow, I did this awesome surgery that's going to make me better. And the reason is because when the surgery was done on Tommy John, back in the 1970s, it did actually cause him to be able to return to pitching. So we're not going to say he did better because we don't really know what he would have done otherwise. But when he returned to playing, he definitely was able to pitch well after the surgery. So this is kind of an interesting, cool picture showing the rupture from Tommy John and the picture of Dr. Job with Tommy John, kind of showing how he could see this rupture of the ulnar collateral ligament. And so you can see there on the far left where the rupture occurred. It's obviously a pretty, you can see the valgus stress at 45 degrees. And it was a pretty significant and pretty obvious injury, I would say. So it usually occurs traumatically, but it can happen insidiously. So it can happen slowly over time from throwing over and over and over again. And that excessive valgus force will then lead to tears. So that's what we've already said. Anterior bundle, usually the most obvious one. And so the anterior bundle is going to restrain that valgus force up to 90 degrees of flexion. And if it's below 60 degrees, then the posterior bundle is involved. So it kind of depends on what position they were in when they injured or what position they get in a lot when they're throwing. It's also most likely to happen during the acceleration phase of throwing, which we'll talk about a little bit more in detail in just a second. So these people are going to demonstrate hyperextension, and valgus is going to increase their instability. So sometimes they'll report that they felt a pop or some sort of pain and they won't be able to throw. Again, sometimes this also just happens over time. There can be some numbness and paresthesia in the fourth and fifth fingers, because it can affect and stretch out the ulnar nerve since it's on the same side and in the same area. And so you definitely want to look for signs and symptoms of ulnar nerve irritability as well. So again, overhead athletes tend to be the ones who have this problem. Pitchers are the most common who end up with getting surgery, but things like javelin throwers, quarterbacks in football, American football, tennis players, water polo players. I would also guess that table tennis players are going to get this problem sometimes. And so we want to talk a little bit about throwing. And again, like I said earlier, we want to understand the phases of throwing so we can understand when these injuries tend to occur. So most of the time, we end up with injuries during this yellow phase here, which is called the late cocking, and then the acceleration phase. So we'll start with stage 1, which is the wind-up of a throw. So when we're talking about throwing, we start with the wind-up, and basically this is the beginning of the throw, right? This is stage 1. The elbow's flexed. There's a little bit of internal rotation of the shoulder or glenohumeral joint. We then have what's called early cocking, which basically starts when the ball moves into the dominant hand from the non-dominant hand, and it ends when the foot strikes the ground, the one in front that's going to help with the acceleration phase. You also have some abduction and external rotation of the glenohumeral joint. And at late cocking, you're going into your greatest amount of abduction and external rotation. So go from early to late cocking, you're hitting that very externally rotated and abducted position, which starts to put stress and strain, valgus force, on that medial collateral ligament. You also have elbow flexion from 90 to about 120 degrees, as well as a combination of pronation of 90 degrees. We then go into stage 4, which is acceleration, and this is where we really have a lot of our muscle coming from, hopefully, the trunk and the hips, and all of the lower body generating large amounts of force so that we can then bring the arm forward. So it's going to be that rapid acceleration of the glenohumeral joint into internal rotation, adduction, and elbow extension. So you can see how this part of the throw is when we're putting the most stress on these two stages, 3 and 4, when we're putting the most stress on the inside of the elbow. We then have stage 5, which is the follow through. And that's basically where we come back to our normal position and we decelerate everything. So again, we want to consider this as we're thinking about returning these patients to sport following surgery, or if they're performing other types of sports or doing conservative treatment, we want to consider these things throughout their non-operative care. So it's not just throwing. We also need to think about the rest of the body. So as I said earlier, we need to be able to have good lower trunk control, hip control, lower extremity control, so core control. We also need to think about where their center of gravity is during throwing, as well as the timing, alignment, and just the different things happening at the joints. So it's a big problem that doesn't just focus on the elbow. And those of you who hopefully will be taking Dean's class or will have already taken Dean's class when you listen to this, he spends his entire 6 days really going through these things in a lot more detail and helping you be able to connect something like the elbow and the shoulder and even the wrist and hand with the hip and the lower extremities. So we diagnose this, we diagnose that MCL or a UCL, so ulnar collateral ligament injury, by doing stress testing in the valgus position. And we also use what's called a moving valgus stress test. And you'll see here that it's 100% sensitive and 73% specific. So sensitive meaning you can rule it in. So if it's a positive test, you can rule it in. But if it's a negative test, you can't necessarily always rule it out. And so basically what it is there's a picture of it here. As the therapist, we're providing a valgus force through elbow flexion and extension. And so we're giving that valgus force throughout full flexion and then quick extension. Okay, and a positive test is basically going to be pain reproduction. This is not where we're looking for actual ligament instability, but we're looking for pain from going from that flexed position with valgus to a quickly extended position with valgus. So you can kind of see that in the picture here. So that test has been proven to kind of be the best for MCL irritability, or possible MCL tear. Sorry about that, MCL tear. We also, of course, will be using some sort of imaging. MRA is considered the best, MRI. It's definitely, of course, very sensitive and specific if there's a full thickness tear, so a grade 3 tear. Maybe less specific if it's a smaller tear, grade 2. As we said before, there's a lot of these athletes and families of athletes who have heard about this surgery, especially in the United States. And so they're coming to doctors and saying, oh, we need this surgery, our kid needs this surgery. But what they're finding is that you may not have to do the surgery. You may be just fine with non-operative rehab. So actually, what you'll see here is we have some research that talks about this and the fact that about 42% can return to their previous level of competition even if they have a tear by just doing rehab. So what you need to recognize, though, is it's a slow process. You need at least 6 weeks and up to 3 months of rest. So no throwing, nothing to the elbow, no force on the elbow at all. And then once that minimum rest time is completed, then we can start focusing or we can start working on the elbow. But previous to that, we want to focus on rotator cuff and scapular stabilization exercises. So anything that doesn't put stress on the elbow is fine. You can do rotator cuff and scapular stabilization. But as we start to incorporate the elbow, we want to start doing elbow flexion and pronator strengthening when the elbow is pain-free. So this is really very, very much focused on pain. If you remember when we talk about the special test, that valgus, the moving valgus stress test, this is related to pain. So this is a good way to follow these patients non-operatively and see whether or not they can start doing things for the elbow. And we're focusing on flexor and pronator strengthening. And then once the mechanics look better, then we can start doing throwing. So we're going to do more elbow strengthening type activities first without pain. And once they can do them without pain, we can move on to throwing. And we'll talk about return to throwing timelines here as well. So again, that non-operative treatment, a large number of our athletes, well, almost 50%, 42% can go back to performing their throwing without surgery. Another good research article that's come out recently talks about platelet-rich plasma. If you remember, we talked about PRP way back in the first lecture about ligaments. And what we have found is that injecting platelet-rich plasma can actually return a lot of our patients to previous levels as well. And there's been some controversy about this in the literature, actually in the news, just generally, in the West about athletes doing this, and then people saying that they were using some sort of performance-enhancing drug. So this can be kind of an issue. But again, if you're just working with non-professional athletes, considering this as a treatment and as part of your non-operative rehab is something that would be very appropriate. So when do we choose to do operations? When is it indicated? Full thickness injury, so again, a grade 3, where there's a full tear, or a partial tear that's not done well with conservative treatment. If they're going to go back to throwing, that might be a reason, but again, we have to really think about the process and the fact that this is a very long rehab program, and it's longer after surgery than it would be with conservative care, so they need to be able to commit to that rehab time. So again, most of the time, if they're a non-throwing athletic population, we're going to do conservative treatment. We're going to do non-operative management. So we have these people that want to come in, coaches of some of these athletes that say, oh my gosh, we need to have our kid, I need to have my player have the surgery. So we need to try to help them understand that it's okay to do conservative treatment in certain situations. There's some really cool things that are out there now. They have little sensors on them at the elbow that can, and up in the upper extremity, that can like figure out which muscles are turning on during things like throwing. And so it actually helps them rehab non-operatively so that we can learn, again, where is the bigger problem? Is the bigger problem at the elbow, or is it really at the shoulder, the scapula, possibly the trunk? So that's nice that we have other options. So again, it's really up to the surgeon, obviously, who has the surgery here, but recognize that they don't need the surgery all the time. So let's watch the surgery and then we'll talk about it. It's a ligament repair that's going to look kind of like ACL. They're definitely replacing the ligament with a tendon. So let's take a look at the video and then we'll talk about it.
The ulnar collateral ligament stabilizes the inside of the elbow through its various flexing and extending motions. This ligament can be ruptured by sudden traumatic accidents, but more commonly, deterioration over time results from stresses related to specific repetitive motions. For this reason, this injury is common among baseball pitchers, javelin throwers, and athletes who play volleyball, racket sports, and other activities requiring overhead throwing movements. In some cases, non-surgical treatments involving rest, anti-inflammatories, and strengthening exercises can provide relief. However, in many cases, particularly in competitive athletes whose damage worsens over time, surgery may be necessary to restore stability to the elbow and improve function. This surgery, known as ulnar collateral ligament reconstruction, or Tommy John surgery, after the LA Dodgers pitcher who first underwent the procedure in 1974 and returned to competitive play, surgically replaces the ligament with a tendon from elsewhere in the body. The ulnar collateral ligament, or UCL, also known as the medial collateral ligament, connects the upper arm bone, the humerus, to the larger of the two bones in the forearm, the ulna, at the elbow joint. A knob-like projection from the humerus on the inner, medial side of the arm is known as the medial epicondyle, and this is the region where the ulnar collateral ligament spans the ulna and humerus. The UCL actually consists of 3 bands, a rounded cord-like anterior bundle that attaches to the front side of the epicondyle, a fan-shaped posterior bundle that attaches to the back of the epicondyle, and a thinner transverse or oblique bundle that merges with the ulnar side of the other two bands. Portions of these ligaments unite with other fibrous tissues to form a capsule that envelops the joint. Outside the capsule, the ulnar nerve passes behind the medial epicondyle and over the posterior bundle of the UCL through what is known as the cubital tunnel. The location and exposure of the ulnar nerve here sometimes cause it to be damaged along with injury to the UCL. If this occurs, it can be moved during UCL reconstruction. The UCL can rupture during a single throw, in which case a pop may be felt along with intense pain. More commonly, degenerative damage to the UCL develops as pain on the inside of the elbow that is felt during and after throwing, or pain in the back of the elbow when the arm is extended. If stress on the elbow also stretches or damages the ulnar nerve, pain, numbness, and tingling may be felt in the ring finger and little finger of the hand. Physical tests, your history and symptoms, and MRI imagery may be used to diagnose and confirm a UCL injury. Tears, detachments, or substantial deterioration of the UCL cause instability in the elbow and make it difficult to throw with speed and control, thereby impacting sports performance. Prior to the procedure, you will be positioned on your back with your body supported and the arm draped and positioned for surgery. You will be given medications such as a nerve block or general anesthesia to prevent the sensation of pain. The arm will be compressed and elevated to remove blood, and a tourniquet is placed to temporarily limit blood flow to the region during the surgical procedure. UCL reconstruction is typically an outpatient procedure where you will be permitted to return home after surgery, which averages around 1.5 hours, but varies based on surgical technique and how tendon used to replace the ligament is obtained. Arthroscopy, in which a small camera is used to see inside the joint, may also be performed before making a larger incision for the procedure in order to look for other problems in the joint that can be addressed during surgery. A tendon will be used to replace the damaged anterior collateral ligament, so it must be harvested and prepared for the procedure. This tendon is usually obtained from you, called an autograft, and less commonly it may come from a cadaver, called an allograft. Most frequently, the palmaris longus tendon from the wrist and forearm region on the same side as the injured elbow is used. This tendon can be removed without impacting hand or wrist function, and is frequently used as a graft for a variety of procedures. However, some people lack this tendon, or there may be a need to use an alternate, such as a portion of another forearm tendon, a tendon from the knee or hamstring, a big toe tendon, or part of the Achilles tendon at the back of the ankle. Small incisions are made to remove enough tendon for the 6 to 7 inches, 15 to 18 centimeters, needed for the reconstruction. The tendon tissue is then cleaned and prepared for the reconstruction procedure. The reconstruction procedure starts with an approximately 3-inch skin incision centered over the UCL on the inside of the elbow. As soft tissue is dissected, nearby nerves are identified and held out of the way. Once the muscle layer is reached, an incision that splits the flexor muscles is made, and they are held apart with retractor devices. Older variations of this procedure would detach the muscles and reattach them later, but today this is often unnecessary. Beneath muscle lies the UCL and joint capsule. The ulnar collateral ligament is split in line with the fibers to access the joint. At this point, surgical variations exist, and new approaches are under study. However, they are generally variations of the traditional and most common approach, in which bone tunnels are created to accept the tendon graft. 2 holes that form a tunnel are created in the ulna, and 2 tunnels that meet in the middle, forming a Y shape, are created in the humerus. Next, suture material, or small wires used to thread the graft through the tunnels, are positioned. The tendon graft is pulled through the ulna, and the ends of the graft are directed toward the lower hole in the humerus. In what is called the figure 8 method, the tendon graft is threaded through the holes in the humerus and then sutured back onto itself, creating a continuous loop in a figure 8 pattern. In a variation known as the docking method, the free ends of the tendon graft are passed through the lower hole in the humerus and pulled taut through the holes on either side of the epicondyle. Next, strong permanent suture material is used to form a bridge across the bone and dock the free end of the tendon graft in the bone. Some surgical variations use fewer tunnels and buttons as anchors or screws that wedge the tendon graft in place. Portions of the tendon may be sutured together for strength. If the ulnar nerve was damaged with the UCL, it may be rerouted from the cubital tunnel to the inside of the elbow joint to avoid stretching the nerve when the arm flexes. After the repair is tested for strength and stability, the muscles and skin are closed. A dressing and bandage will be applied to complete the procedure. You will typically have your arm immobilized with a splint for about 10 days. If non-absorbable sutures are used for the skin incision, they will be removed about the time the splint comes off. You may be requested to wear a special brace that is hinged at the elbow to protect the repair while you recover. Physical therapy starts as soon as feasible. Many patients are able to regain their range of motion within 2 months and can begin careful sports-specific strength training at around 4 months. At around the 6-month mark, athletes may be permitted to practice throwing motions with continued elbow and shoulder strength training. Full pain-free rehabilitation with normal strength and range of motion where one can return to competition usually takes 9 months to a year or more. Ulnar collateral ligament reconstruction, Tommy John surgery, has a high success rate, and some patients actually improve performance. Possible gains in performance are believed to result from strengthening exercises and a better understanding of throwing mechanics after physical therapy, as well as restoring stability to the formerly unstable elbow joint. UCL reconstruction converts a tendon into a functioning ligament, and the majority of patients can return to normal activity and previous levels of competition.
Okay, so you could tell that was, again, I think that's kind of a, what's the word I want to use? Kind of a sales pitch for the surgery. It was a very long video, which is fine, but it's just kind of interesting to me that they really did do a good job on that one. So that's fine. I mean, this slide basically kind of summarizes what you just heard. I think what's important to recognize is that you do have to go through the flexor tendon. So the flexor muscles for the wrist and hand to be able to get to the ulnar collateral ligament. So that's important. You saw there are different techniques for using the tendon. Most of the time the tendon that they use is the palmaris longus. But some people don't have a palmaris longus tendon. It's a tendon we don't actually use, and so some people just don't have one. So if they don't, then we end up using patellar tendon as the most common alternative. And so again, there's just different ways to put that tendon in. And I think what you have to recognize is that it is a very long rehab procedure, and that's something that I think the video did a good job of explaining. Complications, infections can happen. Nerve irritation and numbness is probably one of the most obvious complication that can happen. So we really want to watch that ulnar nerve. About 20% of all baseball pitchers don't return to throwing. So again, this is something you have to keep in mind. And we don't see a lot of baseball in China. I totally recognize that. But if this is a surgery that's happening to any of your other athletes, you just keep in mind that there is that complication rate, or not complication rate, but lack of return to sport. With 37% needing revisions within 3 years, within 3 years. So I think that mostly happens, again, because we're not looking at the rest of the body and trying to figure out why the ligament might have torn to begin with. So we have a very important role with these patients to be able to look at those things. So I put this here because we have to recognize that these types of instability and tears can happen for lots of different reasons. You can have something that's called extension valgus overload, which is another problem that you might see, where there's a little bit more bony growth that needs to be taken out during the surgery. There's more crepitus or locking, catching. So those might be little complications or things that you see before surgery that they're trying to fix, or after surgery, if your body decides they want to develop more fun bone within the joint. And the reason I say that is we're going to talk about ossification problems when we talk about bony surgeries. So the fracture surgeries, we're going to actually talk about this complication at the elbow, and that definitely can be a complication following any surgery at the elbow. So if you do get to see these people before surgery, obviously they're going to stop throwing. We're going to spend time working on elbow flexors and pronators because this is the area where they're going to be moving muscle aside, possibly cutting a little bit through the muscles. So we need to make sure these muscles are really strong before surgery if we can. And then we're spending a lot of time at the shoulder, rotator cuff, scapular muscles, those things. So following surgery, the first phase is the first 3 weeks. And as you saw from the video, the first week or two, they may actually be immobilized. And so if we're not getting them until several weeks later, that's pretty common. By week 2, if we really want to have no evidence of inflammation, that's kind of our goal, as well as no report of just resting pain. We also want to make sure that the wrist has full range of motion. And then by week 3, we want to try to get muscles to start turning on. So the idea is that by week 3 after surgery, we're checking in on our shoulder muscles. We're kind of making sure wrist hand muscles are turning on. We're not doing a lot at the elbow yet, obviously, because they're probably still just coming out of immobilization. So as this says, the first 7 to 10 days, they're going to be in some sort of splint where they don't move. But then by day 10 to day 14, we're going to be in a brace, and you'll see then from day 14 to 21, we're also going to be in a brace. So the first week, we're not doing anything, but by the second and third week, we're going to be in a brace. In that brace, we want them to have flexion only to 100 degrees and extension only to 30 degrees. By the third week, we can go flexion to 115 degrees and extension to 15 degrees. So there's these specific limitations that you want to be following during these first phases. Our treatment as therapists, basically we want to make sure we have range of motion above and below. So that's going to be the shoulder, the wrist, the hand. Make sure all of those things move well in the first 2 weeks. And then by week 3, we can start adding some shoulder isometrics. Again, getting those muscles to start turning on. We also can start doing gentle range of motion into supination and pronation. So remember, that happens at the radial head, which is not going to be affected by the surgery. So we can start doing very gentle motion. If they're out of the cast and in that brace, then we should be able to do that. We also want to make sure the rest of the body is starting to work. So we want to keep cardiovascular health up as well as starting to work on the core, because we know that if their core is not controlling this throwing movement, then that's going to be a big problem as we start to return to more throwing types of activities. Phase 2 is from week 4 to 8. So we're getting into the second month here. And our goals are for range of motion. We want to have full range of motion by the end, or about 145 degrees of flexion by the end of the second month. We're going to still be very careful with varus valgus forces, especially valgus forces, but we want to start doing more functional activities with the wrist and hand as well as the elbow during this phase. So our patient education, again, no valgus forces, guys, none of that during the first couple of months. The week 4 bracing is going to basically be from 0 to 120 degrees of extension. I'm sorry, 10 to 120 degrees. So we're not getting into full extension yet. And then every week after that, we're going to increase the extension by 5 degrees and increase the flexion by 10 degrees. So by week 6, we should have full extension. Our treatment from 4 to 6 weeks is going to be starting some resistive, very, very, very basic resistive exercises. Supination, pronation, a little bit of flexion and extension at the wrist only, and then we can move into flexion and extension at the elbow, and then shoulder external rotation. By week 7 to 8, we can actually start adding internal rotation to our shoulder exercises, and then we can also start doing resistive PNF patterns, diagonal patterns, and then start adding elbow flexion resisted exercises. By phase 3, this goes from week 9 to about 14. Sometimes I've seen it even go into week 16, so about 4 months. And it's at this point that we can start adding some valgus stress, start adding some compression. And so we want to start thinking about multiplanar activities. So this idea is that we're going from single plane activities, so again, just flexion, extension, wrist flexion, extension. Now we're starting to go into these more triplanar, multiplanar type movements. And this is where we're going to start recruiting the legs, the trunk, weight bearing, transferring of weight, moving through all these different movements that will help us get back to throwing eventually. So we can start adding things like the balance discs and the BOSU, foam rollers to stand on. We can put them into high kneeling positions. Again, all of this stuff is stuff that's part of Dean's class, if you want to take his class. And we're just starting to think about sport-specific activities here. We're also doing a good amount of eccentric activities. So eccentric, elbow flexion and extension. We can do eccentric activities for the shoulder, but also progressing rotator cuff exercises. We're going to start just slowly increasing valgus force during this period, and also start doing weight-bearing activities that are focused mostly on the scapula. So what allows us to go from phase 3 to phase 4 is we're going to go back and use that moving valgus test, or what's called a milking stress test, which are both pretty similar. So that was what we used. We talked about that as sort of a diagnostic tool. You can also use that to help you figure out whether or not they can move into phase 4. So if you can perform that moving valgus test without pain, then we can move ourselves into more sport-specific training, which usually, like I said, starts about week 16 or about 4 months. Remember that because they've just gone through this long process, even though maybe they're doing good rehab, they've lost a good amount of their velocity and accuracy. So we really need to start looking at things like neuromuscular control and focusing on that, as well as making sure that their throwing mechanics are correct. But we're really not getting to that until after 4 to 6 months. And if you remember, the video actually even said 6 months. So we can start interval training for throwing, and we're going to do this for multiple sessions at a time. So this here says they're going to go at shorter distances for a certain amount of throws, and then they're going to rest in between, and they're working their way up. So by week 37 to 40, again, so this is way in towards the end of 1 year. Another reference said week 22 to 28. This is when we're going to start throwing more specifically. So this is very focused on baseball, American baseball, and I understand that, but recognize that these timelines are still appropriate even if you're trying to get somebody back to playing tennis and they have to be able to serve, or you're getting somebody back to playing table tennis and they have to be able, obviously, to serve with those as well. So anything where they're having to use their involved side to accelerate through a movement, you want to really consider these timelines. And I know the throwing will be a little bit different, but they really can follow the exact same timelines. So this just talks about how you start off with throwing, and this idea of you do 20 throws at just about 20 feet. I know this is all in feet. Again, it's all very American. And then you go for 25 to 40 throws at 30 to 40 feet. And then you kind of cool down with 20 throws at 20 feet. And then you can see you move up where you're starting to throw at 50 feet, 30 to 40 throws. And then you're going up to 70 feet at 30 to 40 throws. And then you'll notice we get up to 90 feet. So again, this is just the progression. I think that different people will talk about different timelines. This will say you're going to do this for a couple of sessions each before you move on to the next one. So again, if they're demonstrating pain, things like that, you're really kind of going much slower than this, and kind of following and making sure that they can perform each of these stages without pain. So again, I know this is not probably something you guys are going to see a lot, but if you do see it, you are a very, very important part of the process of rehabilitation for these people. The doctor who did the surgery, Frank Jobe, actually has a very interesting quote that basically says that the surgery itself does not automatically make the player better as much as rehab does. So if you don't have good rehab following the surgery, you're not going to be able to get good blood supply back to the tissue, and so you're not going to be as well off as you were before surgery. So it's really, really important that if you do see any of these patients, that you come back and look at these slides. Again, this is not one that you probably have to memorize, but it is important that you have these resources available to you so that if you do need to refer back to them, you have them here so you really can provide the best rehab for these patients.